We're going to talk a little bit about the buccal region. And what some of my thinking about the buccal area is really we talk a lot about mid-face enhancement, upper face enhancement, lower face enhancement, but there's a watershed zone that unifies the mid-face and the lower face. We talk about cheek, 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 jawline, jawline, but how about that unification of those two areas? Remember that what fat grafting does is almost like airbrush work. It unifies the face. It's almost blending the zones. So when I look at fat grafting, you want to look at the target zones for rejuvenation, but you also want to be able to blend in the areas that are not there. And so instead of buccal fat extraction, which has been so commonly talked about, it's the exact opposite. It's putting fat back in the buccal area. And I divide it down into three areas, into the medial area, which is really where we lose a lot of dentition. The canine fossa is an extension of that, so this sinking into the medial area. The central area, which is where we all lose a little bit, and that's the major target of focus. And then some people that are very gaunt laterally, you want to go and widen that face to create a little more aesthetic balance, and that's at the backfill area that lies somewhere underneath the zygomatic arch. So this is just a little illustration showing you the subdivisions in the buccal area and the refinement of the concept of the buccal area. And this is just showing you the central buccal area. This is the lateral buccal area, and actually it does tilt almost 90 degrees back to go underneath the bone. You can see the arrows where I'm trying to show you that. And then this is the medial area, the area right across here. The only caveat you want to express to the patient when you fill the medial area is it does worsen for about 2 to 4 weeks, this area right around the mouth, the labiomandibular sulcus, and that can look not so good in the short run. This is a lady that I did plasma resurfacing on, a little bit of upper eyelid bleph, and I did fat transfer on. And this is really looking at the center. Didn't really go too far out, just really focusing toward the central area. You could argue to go a little bit further out. I was really focused not to widen the face too much on her. The lady you saw earlier was a more extensive buccal area, and if you ask me what's the most important area for me to work on, you may say, oh, we'll work on the eyes. But I really believe if I had to put a little Restylane in, for example, the area I would focus on is in the buccal area. That is what ages her the most. So I did a backfill, central area, and then toward the dentition in the medial aspect. And I think if you can blend that area, you create a more unified face. This is my own mom, and with Asians you tend to have a very heavy lower face, so you want to pull the anterior chin and the upper cheek area forward, and you want to stay very clear of the medial area. I put probably about a half a cc in the buccal area just to transition. It was only the central area, but very minimal buccal fill. This is a young lady, only 39, little Botox, lip enhancement, a little bit of plasma resurfacing to clean up the skin, and then this is another 3-part fill where the back fill, the central area, and the medial area are hollow. So even for a younger lady, I think you just got to look for all the zones that need to be filled. This is a lady here that if you look, she has a sort of a pushy quality to the medial aspect with a little bit of exaggeration of the hollow underneath the arch. So this is a little bit extension out to the outer portion of the buccal area, but being very careful because she's got a somewhat wider face. So it's a little bit central, a little bit less toward the outer portion, and then staying clear of the medial buccal area. And she also had an upper bleph. She also had a lower eyelid bleph, transconjunctival. She also had plasma skin resurfacing, and you can see that. I think this is a better frame to the face frame to the eye that we talked about. This is no facelift or brow lift or anything like that. Keeping the brows low and full and balanced, I think, creates a younger look. Let's talk about the lower face. We heard a little bit about the pre-jowl area. I want to focus specifically on a concept here, which I think it helps you conceptualize as better, which is the upside down U. Looking at this as a continuous area of hollow that arches all the way across. And oftentimes, we're very focused on the jowl and the labiomandibular sulcus as the issues, but perhaps we should be looking at something else. When I see an aging chin, what I see is a central bone island sticking out. And what I try to do is blend and soften around it to join it with the surrounding areas. So it's almost like when you see the vase of a woman, a vase with the side profile of a woman, what are you looking at? This is the same thing. I'm looking at the hollow instead of looking at the fold and the jowl. So it's just a little bit of rethinking and refocusing on what I think is important. So it's just filling in not only the pre-jowl area, but really focusing on the anterior chin, not so much the line or the fold, and not so much on the jowl, but just this whole continuous zone. So this is just showing you filling the pre-jowl area you saw before, and then filling the anterior chin area and blending that whole area as one arc. There's a lady here that actually looks thinner after fat grafting because I was able to bring the anterior chin forward and the cheek forward, but also what I've done is really soften that upside down U and blended it in with the surrounding areas. This is no facelift, liposuction, or anything else. Here's a lady that's on the left had the brow lift, the eyelid surgery, and the facelift, and she's 55 and really not rejuvenated. She needed the blending of volume in all the right places. And you can see that anterior hollow that sits there. It's not just a mental sulcus, it's the bone exposure that is apparent circumferentially around the chin area. Let's talk about stem cells. We heard a lot about that. I think it's a very interesting concept. Again, I like to use the hair transplant model. I was in Montreal a couple weeks ago for the ISHRS, International Society of Hair Restoration Surgery. Some really interesting concepts have been developing about the interaction of the recipient site to what you graft over there. For example, if you have a scarring alopecia like lupus, discoid lupus, and you transplant hairs into that area, you actually start to soften the scar, and it looks normal over time. To me, that's really exciting information. So I think there's something about the transplant model of putting a graft in there and the effect that it has locally. I've seen some scar reduction, pigment changes. I had a lady that went back to California and to see her family, and the family didn't even notice my fat grafting, except what I worked for 3 years on, brown spots, finally faded just with a fat grafting. Now obviously you want to be really careful of making these comments because they're not necessarily consistent changes, but they're interesting changes. You don't want to offer this to a prospective patient as a promise or a guarantee, but just interesting concepts for you to observe as you mature and continue with fat transfer. This is a 55-year-old Korean lady who wanted to come in for facial rejuvenation and acne scars. And I decided just to do the fat grafting because, you know, dermabrasion, fillers, things like that, other things that would require some downtime for an Asian, I just thought, let's put some fat in there. And this is about 9 months out. I actually haven't seen her back, but it's a really nice change to that texture and tone of the skin, and I'm just really excited about this. This is a charity case I did for a lady that was in a car accident, and what was really exciting is this is the same room, same lighting, same distance, but there's just better texture overall, and the scar that she's undergone multiple scar revisions for that's become atrophic has really softened by 80%. It's not perfect, and this is about a year out. I'm really curious to see her 2 years out. In fact, when I did this procedure, she had so much scar tissue that my cannula almost broke. It was so difficult. I thought her fat take would be 0, but out of this, even in this circumstance, I think it's a nice textural change. Maybe that's where she got most of her benefit. Long-term safety, I just want to emphasize one more time, I think the focus of what you can get out of this talk is be careful of overfilling and be careful of the early touch-up. I think there's an evolution to the change of the result that you want to be wary of. And one more thing that I learned from Val Lambros is really just being careful of thinking of using this as a reconstructive modality, because sometimes if you've got a deficient mandible and you put fat in there, because there's an evolving shape change, this can actually be larger over time and grow to distortion. So I usually, if there's minor asymmetries, I may go and just feather a little bit more. But generally speaking, I keep pretty symmetric volumes on almost everything that I do because fat is not a bioinert substance, it's a live graft, and that's something you need to understand that. So I appreciate your attention.